Hello, my name is Dr. Ukiri Richard. Now we continue our podcast on basic cardiology. Today we are going to talk about sudden reduction in exercise tolerance. The case today is that of a 62-year-old male patient that came to your outpatient because he has been experiencing a drastically reduced exercise tolerance since 1 week, and he can hardly carry out mild exertion. Physical exertion. When you check his blood pressure, you notice that the pulse was slow. In his past history, he is known to have a coronary heart disease, and 4 years ago he had stents in LAD and right coronary arteries. Thereafter, he had never had angina pectoris symptoms. Atherogenic risk factors are arterial hypertonus and an ex-smoker. What tests are you going to request for? Well, I'll request for a routine laboratory test, an ECG. I'll do an ECG Holter and echocardiogram. Okay, you did the laboratory test where you found an elevated creatinine of 2.0 mg per dl. Hemoglobin was 11.9 gram per dl. The other values were normal. In the echogram, the aortic root was normally wide. The aortic valve was thickened with a reduced opening surface area. There were no insufficiency. Vmax 3.45 meters per second with a maximum pressure gradient of 48 millimeters of mercury and mean pressure gradient of 23 millimeters of mercury. There was an opening area of 1.2 centimeters squared, which is indicative of a moderate aortic valve stenosis. The right atrium was visualized to be normal. The left atrium slightly dilated. Right ventricle was normal. Left ventricle was also slightly dilated with normal wall thickening. The systolic global function was borderline according to planimetric measurements. An ejection function of 55% was measured. The diastolic global function was normal. The mitral valve was thickened with normal movement and mild ease of regurgitation. There were no stenosis or ring calcification. Tricuspid valve values were those aspirated from the age. The right atrium, right ventricle gradient could not be measured. There were no pericardial effusion. You did the ECG and these are the findings. You have sinus rhythm with a ventricular frequency heart rate of 44 per minute. There was left azic and you saw an AV block grade 2 with negative T waves in 1 and AVL. My question is, can you actually classify the AV block grade 2 based on this short ECG stripe you are seeing? Well, there are two types of Mobitz block. There are two types of AV block 2. There's the Mobitz block, which is Wenckebach, Mobitz block type 1, which is Wenckebach, and Mobitz block type 2. But in the Mobitz block type 1, which is Wenckebach, there's a progressively increasing PQ time until there is a failure of AV conduction. In the Mobitz type 2, there is a constant PQ time, but however, it will come to a time where there is a failure of AV conduction. The site of the blockage is by the two types different. The blockage in the Mobitz type 2 is actually under the AV node, which is infrahysia, which is why it is very, very possible to lead to a higher progression to a complete AV block. In this ECG we are seeing, it is difficult to say if it's an AV block 2 type 1 or type 2, because after every second, because there's a failure in AV conduction in every second beat. So the two is possible to be any of the two. How do you define AV block 3, grade 3? Well, in AV block 3, there is no conduction of atrial action to the ventricles. This block can be intermittent or permanent. The excitation of the ventricle actually comes from a lower center. If the lower center is in the AV node or his bundle, then the QROS time is usually below 120 milliseconds. The rule is that rule of the thumb is that the lower the secondary or tertiary pacemaker centrum lies, the longer the lower centrum. Especially patients with chamber replacement rhythm lower than 40 per minute usually have syncopes. So you did a 24-hour ECG Holter where you have seen 3 channels. You saw that the PQ time was progressively increasing until the 4th one was not conducted to the ventricle, and the 5th one showed a shortened PQ time. Now my question is, how do you see indication for a pacemaker therapy in this patient with AV conduction disturbance? Well, let me run down the indication for pacemaker therapy in AV block. 1, if you have a chronic symptomatic AV block, grade 3 or 2, either MOBIS 1 or 2, is a class 1C. If you have a neuromuscular disease, for example, myotonic muscular dystrophy with AV block 2 or 3, is a class 1B. Any AV block 2 or 3 after catheter ablation of the AV junction or after heart valve operation, when you don't expect a normalization, is a class 1C. Asymptomatic AV block grade 3 or 2, either MOBIS or 1, is a class 2A. Even AV block grade 1 that is symptomatic is a class 2A. AV block grade 1 with myotonic muscular dystrophy, that is neuromuscular disease, is a class 2B indication. But generally there's a class 3 indication for all asymptomatic AV block 1, asymptomatic AV block 2, MOBIS 1 with suprahis conduction, and AV block where you expect a normalization. Okay, this your patient actually got a pacemaker implanted, and now I'm showing the ECG that was done after the implantation. Could you? Okay, let me tell you what is coming out here. You have a spontaneous sinus rhythm. After the passage of the programmed AV delay, you have an atrium triggered stimulation of the ventricle. My question now is this prolonged AV delay in order to support the intrinsic ventricular action, is it wise? Well, from scientific data, we have indications that this can have a negative or necessary count from the right ventricular stimulation. And in this patient that already has a background of heart failure, it has a prognostic importance. Even in patients that have sustained left ventricular functions, through high right ventricular stimulation, they have more episodes of atrial fibrillation. And from a recent study also to a worsened left ventricular function. Well, the new pacemaker algorithm allows for an automatic mode change between AAI and DDD stimulation, so as to prevent unwanted or exaggerated right ventricular stimulation. In our patients, we are seeing that due to the prolonged AV delay, which is also called the AV hysteresis, is coming to right ventricular stimulation. Thank you very much.